Welcome to the Low Carb MD Podcast. No one is beyond help. No one is beyond hope. Nothing said on the Low Carb MD Podcast is medical advice. Please consult your own doctor before making any lifestyle changes.
Welcome back to the Low Carb MD Podcast. I am excited to have our guest on today, somebody I met last year at Boca Raton when we had a conference dedicated to type 1 diabetes, the autoimmune, and sometimes the type of diabetes that requires insulin. I'm sure most of my listeners know what that is. And I am so upset. Dr. Brian Lenskis, my co-host, is out today. He sends his regards to Dr. Ian Lake, who is joining us today, all the way from the UK. And if you have not seen him lecture, if you have not read one of his papers, you may know him from his stint with 05100, which made a huge splash, was in the news several years back. And it was to raise awareness about the ability of type 1 diabetics to use ketones during exercise. And this brought a lot of attention to the space. And Dr. Ian Lake, besides practicing for the last 4 decades in the NHS system, being a GP, he himself is type 1. He's been a huge advocate for type 1 diabetes. He has lectured around the world on type 1 diabetes. And his most recent paper, which I found very interesting, and we'll certainly put a link to it in the show notes, was a case report and a discussion around the ketogenic diet, relieving the anxiety and the depression that's associated with insulin-dependent diabetes. It was absolutely fascinating. And, to top this all off, Dr. Ian Lake and I have had the pleasure of working together on the type 1 consensus statement, which by the time this comes out will hopefully be through submission. So Dr. Ian Lake, it's an absolute pleasure to have you. Thank you for joining me today. And Dr. Brian Lenskis sends his warmest regards, and he's so upset he couldn't make it today.
Well, thank you, Dr. Tro, for that wonderful introduction. It's been nice working with you on the position statement on type 1 and meeting you finally in Boca Raton.
Yeah, so let's, I always like to start, most of our listeners understand that type 1 diabetes, for the most part, is an autoimmune condition, although it's not always. But for the most part, it's autoimmune, oftentimes starting in youth, but it can be developed later on in life, and that's called LADA. This is a very unique population, what I consider a very vulnerable population. And let's start off with some statistics to get the discussion going. The average patient with type 1 diabetes lives anywhere from 10 to 15 years, dies 10 to 15 years younger than other counterparts. They are much more likely to suffer from depression, anxiety, much more likely to have a heart attack, much more likely to have a foot infection or amputation, and oftentimes can suffer from a host of issues, but some of which are very severe regarding their fluctuations in blood sugar. And often many type 1 patients live in fear of very high levels and potentially going into ketoacidosis and very low levels of blood sugar and potentially going into a coma. So it's absolutely a debilitating condition. And I think it's very hard for the average person to sort of wrap their heads around this. And now you've not only have you seen this clinically, but you've also lived the experience and published on it. So I don't think there's a person in the world who may be as qualified as you, maybe a couple, who are as qualified as you to really talk on this space. So can you help us understand, I guess, from each of those lenses, your clinician lens, your patient lens, and your sort of researcher lens, can you impart some insight on us on type 1?
Yeah, thank you. So I'm one of the people called a LADA, which is a latent autoimmune disease of adulthood. So I developed mine almost 30 years ago. About a third of us develop LADA, which is an autoimmune type of diabetes. About a third develop it in childhood, and about a third in sort of teens, late teens, mid-teens. So it's often thought of as a childhood disease, but it really isn't, and it can pop up at any time. Um, I think there's a bit of confusion around type 1 diabetes. It's always linked with blood sugar. And of course, blood sugar is the obvious marker for type 1 diabetes. When we diagnose type 1 diabetes, we measure glucose in the urine and more often in the blood. And that tells us whether or not a person has diabetes. And then the second stage of that is to find out what type of diabetes it is by measuring things like autoantibodies, etc. Um, you can also get type 1 diabetes by having your pancreas removed and, pancreatectomy after something called acute pancreatitis, which is a life-threatening condition. It causes a more severe form of type 1 diabetes in many ways because people who have had that condition can't deal with low blood sugars either very effectively. So diabetes lived every day becomes a habit. You talked about the complications. I mean, what we worry about now. So what I'm worried about now, well, I'm not worried because I know I'm okay. But what I'm worried about every day is, am I going to go hypo? Is my blood sugar going to dip? Okay, so if you go hypo, it means your blood sugar goes below the level at which after which you start to get the effects of a hypo. They're very variable in people, and I looked at a list which I put out in a questionnaire, and there are about 15 or so symptoms. The common ones are feeling anxious, feeling aggressive, feeling hungry. Sweating is a very, very common side effect. Some people get spots in front of the vision. Some people get headaches. Most people get a bit confused and start repeating themselves, or get stuck. If I'm having a night hypo, I will have a recurring dream where I'm stuck in a building and can't get out of it. That sort of thing. It's a repetitive thing. And I think you see that in people with type 1 who are hypo. They start talking a little bit nonsensical, really, in many ways. That is because their blood sugar's low. And the only reason their blood sugar's low is because they've got more insulin in their body at that particular moment in time than is ideal. And all of the other systems in the body which bring blood sugar up can't cope. So one of the functions, so we worry about that every single day, really. That's every time you go and do something, go for a walk, go to do a GP clinic, go and talk to an audience, etc., drive in your cars. You're concerned what your blood sugar is. So you have to be on it all the time. You can worry a little bit about going too high, but going too high doesn't cause that many symptoms until it's very, very high for a long time. Mostly people will recognize it as a little bit of like what you call a postprandial after a big lunchtime meal, sort of that. It feels a bit like that. You feel a bit hot, you feel a little bit nauseous, you feel a bit tired, very tired indeed. And that's a very common symptom, especially in people with type 2 diabetes who have high blood sugars for quite a lot of the time. And they're dozing off all the time and think it's because of their age, because it often happens in the older age group, but it's probably partly their age and partly their high blood sugar levels. So they're the things we worry about every day. And then, of course, in the back of our minds, on day one, when you get diabetes, you're told about all the complications that Dr. Tro just told you about. And of course, added to that is kidney failure and blindness. And of course, you're told that on day one, and you're told, well, if you control your blood glucose really, really well, you'll be okay. Now, what they don't tell you is this is very, very difficult to control your blood glucose by conventional means. So I'm an NHS GP. I'm trained in the National Health Service. I do all of my training using NHS-approved training aids. So I'm up to date. I was up to date when I was diagnosed with all of my diabetes management in the primary care setting, which it's not a difficult condition in many ways in theory to manage. If you eat a lot of carbohydrates, your blood sugar goes up. And then in order to stop your blood sugar going up, you take insulin, which your body has now stopped making. So people who have type 1 diabetes just don't make insulin. So you have to inject insulin at the right time to try to catch the spike of sugar that happens as a result of eating. And you'll be doing that 3 times a day if you're eating 3 meals a day. And of course, historically, people with type 1 diabetes were advised to have snacks in the middle of the day. Now, the snack idea came about because the types of insulin available in the early days of diabetes were not very sensitive, and they sort of had a long period of action. They mixed them together. There's one called mixed hard. So there's some relatively rapid acting insulin, not as rapid as modern insulins. And then there's a slow acting insulin. And they were mixed together in the same vial. So you injected that twice a day. And then somehow you had to anticipate the blood glucose drop as a result of the fast acting insulin, which had a wide time of action from about 1.5 to about 5 to 6 hours or more. And then that was when the idea of digestive biscuits and all these complex carbohydrates, so-called, came about. So the life of a type 1 before PENS was that you had a carbohydrate meal in the morning, you had a mid-morning snack, and then you had a lunch. And then to cover the effect of the long-acting insulin, if your lunch wasn't enough, then you had a mid-afternoon snack and then an evening meal, possibly also a nighttime meal. In those days, there's no such thing as a continuous glucose meter, and everyone had to use finger prick testing in order to test their blood sugar. Finger prick testing is good. It's very inconvenient a lot of times. It's a little bit time consuming. It takes about a minute or two, but when you have to get your kit out of the bag, wash your hands, finger prick, stop bleeding, it's a significant part. You don't want to be testing it all day, every day. So but people do, and you have to. So historically, diabetes was limited by the sensitivity and the technology of the development of the insulin molecule. And because of that, the diet for people with type 1 diabetes was more restricted. They said you mustn't have sweet foods, you mustn't have ultra-processed foods, and there weren't that many around in those days. You must have, if you're going to have carbohydrates, they must be from healthy sort of whole food sources. But you cut down on those. But you have to have more rapid acting carbohydrates to catch any potential hypos. Very complex in those days, very restricting. And then in the early 80s came out the Novo Rapid and subsequent rapid acting insulins, of which we now have one called Fias, which has a claim to be rapid acting, but it's not much faster than Novo Rapid in reality. But all these rapid acting insulins came about, and at the same time, wonderful, came out the insulin pen, which most of us now have been using at some point in our insulin journeys. So the insulin pen with a rapid acting insulin said, hey, hi guys, you now do not need to worry about when you eat. You have freedom about when you eat. And these pens will mop up any carbohydrates very quickly for you. So that must have been wonderful as both a patient and a diabetologist. It must have been wonderful to be able to free up your patients to eat when they wanted. At the same time, roughly, was this idea that heart disease could be improved by reducing fat in the diet. And because people with type 1 diabetes tend to have about 3 times more heart attacks at an earlier age than people without diabetes, the argument went, well, we better use the same diet for people with type 1 diabetes as those without diabetes. So the low-fat diet became part of the people with type 1 diabetes menu. And as a result of low fat, to make up the numbers, we had to have higher carbohydrates. But we were reassured that didn't matter because the rapid-acting insulins would cover for the carbohydrates in the meals. So you were not only being given freedom to eat when you liked, but now you were being given freedom to eat what you liked, in the hope that it would reduce the incidence of cardiovascular disease, which it manifestly hasn't done. It's failed to do that.
So this was like pharma's, the pharmaceutical industry came to their sort of help, and it was a huge innovation, and I'd imagine, and I don't have to imagine, you could probably tell me, and certainly your case report alluded to that. The life of the diet of the day-to-day life is, every, bit of food has to be accounted for. You have to, sort of really think about what you're eating, inject based on what you're eating. I think the average person just can't understand what it's like. The closest thing I could say is go back and remember what it was like to bank before, use a checking account before
Yeah.
the apps came out, where you write a check, you pay for a bill, you write it down. I mean, it's that sort of level of involvement, and maybe
Yeah,
even more than that.
yeah, one person put it well. They said, well, when you inject insulin, of course, it has a variable onset of action depending on if you inject into a scar, if you inject into a blood vessel or whatever. It doesn't always get into the bloodstream on time, and your food is not always absorbed from your gastrointestinal system at the same rate, depending on what your gastrointestinal system's doing at the time. So he said it's a bit like making it in when you're driving, making an input about 5 minutes before you actually reach that bend.
Yeah.
So
Yeah.
it is a technical exercise. So 10 years ago, having struggled and struggled to get this right and finding it almost impossible to balance the insulin and the carbohydrates, I read Richard Bernstein's Diabetes Solution, which was revolutionary for me. I put it down because I thought it's a bit too fat, it's a bit too much, it's a bit too prescriptive and far too much fat in there, and there's not a lot of healthy whole grains. Oh my goodness, it makes me embarrassed to think of that now. But at the time, I put it down and then picked it up again 6 months later, and I ate my first keto meal, and I haven't looked back since. And it became blindingly obvious, having done some pretty basic research, that yes, reducing carbohydrates in the diet for someone with type 1 diabetes is such a logical thing to do. It's impossible to understand why, in 2024, we still have significant number of clinicians saying you need carbohydrates if you have type 1 diabetes because you need energy. And if you don't get energy, of course, you won't do very well. And of course, that is completely untrue. You do not need to eat carbohydrates. Your body will make enough for your needs. And fat is a much more potent fuel than carbohydrates, unless you're performing at probably the very highest level, which 99.999% of us will never do. So for practical purposes, I discovered that carbohydrates are an unnecessary component of the diet. Just to give it some context, 10 years ago, almost to the year, well, it is to the year, I decided to cycle around the North Sea, which not very big compared to the Atlantic Ocean, but it was 3,500 miles over 10 weeks. So it's a fairly leisurely cycle trip. But I felt that my HbA1c was about 8 and a bit percent at the time. So it's quite high. It's nothing to be proud of.
Which is the average for a type 1. So 8 is unfortunately the results of our standard care here in the United States, an A1C of 8, which
Yes.
is rather tragic, but that is in 2024 the average A1C.
Yeah.
So, and back 10 years ago, it was probably around 8.5, the average A1C. So you were
Sure.
doing better than average.
Thank you.
Yeah.
But to add to that, 7.5% is now considered a good target, and 70% of people in England, in my country, do not reach that target. And at that level, you lose 100 days of life every year, whether you're a type 1 or a type 2. So that's quite profound to think that. So after that trip of 10 weeks and lots of physical activity, I thought, well, I'll mitigate the disaster of my poor sugar control with physical activity, because we know physical activity is protective against heart disease, blah, blah, blah. So my HbA1c came down from, say, 8% to 7.8% or whatever. And within 3 months of going keto, it came down from 7.8% to 6.5% within 3 months. So I knew I was, and that attests to the benefit of getting the diet right. So it's
I'm curious. So, this is, pumps were coming around about 10 years ago. So this is all sort of manual you were manually dosing, right? I mean, just to, we haven't gotten to the innovation of pumps yet in the story of your sort of the history of type 1 diabetes. So at any point, did you transition to a pump? Were you using a pump? Have you since, or are you still sort of manually injecting?
Yeah, I'm still manual right now. I'm just started to think about the need to apply for a pump. And I'm in the process of acquiring one, but that is much more difficult than you think in where I live. The
Oh
waiting
yeah.
list is 4 years.
In the United States, I was looking at the statistics, 60% use a pump here in the
Mm.
United States, which I found, and I think in the UK it's like 20%. Does that sound about right?
Yeah, they're
Yeah.
trying to make it accessible for every type 1 within the next 4 years. But the current rate of funding for my area, it's 100 years. But
Oh
it will
wow.
be increased to 4 years very soon. So I'm on pens at the moment. So yeah, so that's my story really. And then I converted rapidly to a keto diet and have remained on it. And my HbA1c only once has been above the diabetes threshold in the last 10 years. The vast majority of the time it's under 6%. So it's a
So
remark to think that.
that is absolutely remarkable, and I think one of the things we take for granted is, as a clinician, it may have been more easy for you to adopt Bernstein, and let's just give the listener a little background into who Dr. Bernstein is. Dr. Bernstein is a 94-year-old endocrinologist who is actually very close to where I live. He practices very close to me in the New York area. And he's lived with diabetes for, I want to say, 50 years. And he was very much a proponent of low carb diets for nearly 4 decades. And there are some old interviews with him fighting with dietitians, on the news. And certainly his book, Diabetes Revolution, if I remember correctly, is an absolutely fantastic, a must read. And
It's,
based off of his principles is the Type 1 Grit Facebook group. So if you're a Type 1 patient, that Type 1 Grit Facebook group is absolutely invaluable. Or the Diabetes Solution. Sorry, that was the name
it
of the
is.
book.
Yeah.
Yeah. And
There's a film out now, The Diabetes. If anyone wants to watch the film, it's 56 minutes. It's a download and it's absolutely so persuasive. It will convince anyone that for children, certainly, a keto diet is something they should look into at least.
he was there's a lot of sort of naysayers about CGM use. Um, but he was one of the first proponents of just the finger stick. So
Yeah.
he saw the arguments against using a finger stick glucose meter back in the 80s, and he was testing on himself, very frequently back then against the quote unquote guidelines. So he's seen the guidelines slowly change over time, and he's had to push hard against those guidelines. And I'd like to just give the listener a brief understanding, Dr. Lake, if you can. Can you give the listener an idea of what the guidelines say now with regards to sort of nutrition and medical nutrition and the management of type 1, just to give the listener, because we have a lot of people who are interested in metabolic health and do low carb, but and they may think that this is aggressively promoted right now, but can you give the listener an idea of sort of what is the standard of care right now?
At the moment for type 1 diabetes, it aligns very much with the standard diet in both the States and the UK, which recommends 15% protein, 35% fat, most of which should be unsaturated, and 55 or more percent carbs, whatever, to make up the 100%. So it's still carbohydrate based. Our new guidelines do say that refined sugar should be discouraged down to 10% of the total carbohydrate load. And our guidelines don't actually, for type 1s anymore, specify any particular diet. But the dietary guidelines are the ones that most people with type 1 diabetes who are clinicians adhere to fairly well. So it's a high carbohydrate, low fat diet, low salt diet.
So they recommend a high carb diet, or at least the USDA standard diet.
Yeah.
Now, in the US, I know the ADA has 4 healthy eating patterns per their definition, the American Diabetes Association, uh, and one of which is DASH or
Yeah.
Mediterranean, one of which is low fat.
Mm.
They list low carb as one, and then they have plant-based as the last one. So these are 3 out of the 4 diets that are recommended are still very high in carbohydrate. And then under the type 1 category, they caveat that although there's some good evidence for very low carbohydrates, that no diet has been well studied in type 1. And with regards to management of type 1, I think that they recommend an A1C target of, I believe, around 7 to 7.5.
Yeah.
But when I'm interpreting this data through a critical lens, I'm looking at this like, okay, so they're telling my patients to include carbohydrates, 3 out of 4 diets included, and then they're telling them to essentially, they're saying cover with insulin, and then accept an A1C of 7. And the scientist in me says we need more data. The human in me says this is unacceptable. So which side of me should I listen to?
I think we should listen to the science, and the science will lead you to your instinct about type 1 diabetes. Type 1 diabetes, we have to look at the science of type 1 diabetes. Type 1 diabetes is nothing particularly to do with carbohydrates, and it's everything to do with insulin. We, as type 1s, do not produce insulin. Insulin is the prime hormone, it's probably the only hormone that reduces blood glucose. So we have many other life processes that raise blood glucose, and insulin intervenes at a very minimal level in most cases, apart from with diet, to bring the blood glucose into the normal range. Now, the normal range is very, very narrow, 54 to 7 times 18, whatever that is. But it's to 890 or something like that. It's a very narrow range. And blood glucose is sensed in the pancreas to go above the higher number. Insulin is secreted and pulsed out every 15 minutes. But it isn't needed in that great an amount. So when we did the 05100, I needed 2 units of insulin when I was fasting. So I don't need a huge amount. The body does not need a huge amount of insulin if
2 units per hour, right? Is that what you're suggesting?
No, that was 2 units per 24 hours during that.
Oh my gosh, geez.
And so did my fellow type 1 as well, which goes to show that you need insulin to get amino acids into cells. You don't need insulin to get glucose into cells, only specialist cells, which are obviously fat cells and muscle. But if you're burning fat, you do not need much insulin. But insulin you need as an energy regulator. I caveat that I was on this. So I say body insulin lasts 15 minutes. Well, I'm injecting insulin which lasts 33 hours. So the long-acting insulin. So you've got that to contend with, and I'm sure some of that insulin was being used when I wasn't taking any insulin, or 2 units of insulin that was being used. But what I'm trying to say is you need tiny doses of insulin. When I just done a cycle trip from England to Switzerland, which is just over 1,000 miles, and my insulin volume halved. I was taking about 10 units a day when I was exercising for 6 hours in the heart rate zone 2 to 3. So not particularly strenuous exercise, and the insulin volume halved. So we don't, I think, need as much insulin as we think, but we do need insulin, and it goes up most dramatically when we eat carbohydrates. So if we're eating carbohydrates, we need a lot of insulin. I think that we need to look at a healthy human, and as type 1s and say, well, how can they live a healthy life without eating much insulin, without using much insulin? So they will be eating a very low carbohydrate diet. They'll be doing plenty of physical activity. They'll be getting plenty of sleep and good quality sleep. They will be mixing with their communities and reducing their stress levels. And they'll be respecting their what I call circadian rhythm, which is all those processes which can raise blood glucose if your body rhythms are out of sync. And you look at what those people do and say, well, can we do that as people with type 1 diabetes? We possibly can. But the way insulin works, we're injecting it into the skin and not into the right place, which is in the portal system, the blood vessels around the pancreas and the liver. We're injecting it into the wrong place. But we can approximate to that if we study what I call the 5 roots of health, of which one, of course, is diet. And the high carbohydrate diet is, has to go if you're going to reduce your insulin. The fantastic and fortunate thing for type 1s is that you do not need carbohydrates to live. Your body will make them, but you do not need to consume them to live. So if none of us ate another carbohydrate ever again, we would remain healthy, which is fantastic, really. So for type 1s, so diet forms a large part of diabetes control, but I think we should be studying how to reduce the insulin, because when we do that, the glucose will follow. The glucose will be fairly stable if you're creating conditions where you don't need too much insulin. Because if you're in a situation where you need a lot more insulin, it means that your sugar's going up all the time, your blood sugar's going up all the time. So insulin's got to keep bringing it down. And therefore you're what I call hyperinsulinemic. You have too much insulin in your body. Now we're starting to understand, and there are lots of authors in this space now, that some mental health conditions such as bipolar disease, we know that epilepsy is to some degree helped, and a lot in many ways, lots of different types of epilepsy, but some epilepsies are cured by a ketogenic diet. We know that bipolar disease is helped. We know that migraines are helped. We also know that Alzheimer's disease may well be caused by high levels of insulin. And there is some work on cancer, because insulin is a growth promoting hormone. It's an anabolic hormone. We have evidence in cancer that high insulin levels aren't good in cancer. That has to be explored a lot more. So it seems to me that if we have an opportunity to reduce our insulin volumes, we'll never, as type 1s, we have to be realistic. It's not a race to the bottom. I'm under no illusions I'm never going to get off insulin. That's not a problem. I have to accept that, because if I don't take insulin, I'll be dead by end of the week. So it's a very vital hormone, but I think if we respect it and use it wisely, I think we can then reduce our insulin and help other aspects of our health other than just reducing diabetes complications. You have to think, don't you? The evidence coming out about bipolar disease, manic depressive psychosis, whatever you want to call it, is that keto diets are hugely effective in this condition. So what if you get a type 1? What if that person then develops type 1 diabetes? There's a clinical conundrum at the moment with conventional practice, where you say you must never be in ketosis, against the needs of somebody with bipolar who has to be in ketosis. So there's this idea that certain tissues need different types of fuel. And that in itself presents a challenge for us people with type 1 diabetes. And if I could briefly explain why that may be. Insulin is an anabolic fat storage hormone. It also gets protein, amino acids into cells. It is also non-carbohydrate dependent, but it regulates cellular energy in the brain and elsewhere. So insulin is a very complex molecule present in a healthy adult in relatively low levels for most part. Now, if you are eating a lot of carbohydrates and you're not exercising, and your blood glucose goes up, all of that insulin will be devoted to converting that carbohydrate into fat in your liver. And that's why people get fatty liver if they're having continual carbohydrates and have continually high insulin. Now, what that does, if you're storing fat, you cannot burn fat. And if you can't burn fat, you can't make ketones, because ketones are a side effect, or an inevitable effect in the liver of fat burning. So here we have a hormone, insulin. We're told we should never go into ketosis, which is quite right if you're taking a high amount of carbs. I fully agree with that. But if you're taking very few carbs, you will not be storing fat. You will then be burning it, because as the levels of insulin drop, if you think about the sort of the seesaw, if the levels of insulin drop, fat burning goes up. If the level of insulin goes up, fat burning goes down. And of course, if fat burning produces ketones, if insulin's high, ketones are zero. If insulin's low, ketones go up. So if you're on low insulin volumes, which I think we should be, therefore you're enabling your body to free up two other fuels, certainly, fatty acids and ketone bodies, which some tissues of the body prefer. And like the example I gave about manic depression or bipolar disease, those tissues do well with ketones. If you have type 1 diabetes, you're suppressing ketosis in the conventional diet. And therefore, I feel that the diet needs to be targeted for people with type 1. We can't just take the guidelines for everyone else and say, oh, we'll do the same as everyone else. Type 1s can live lives the same as everyone else. Yes, we absolutely can. We can climb Everest, we can blah, blah, blah. But we can equally do it if we respect our insulin and allow our bodies to multi-fuel. So I think multi-fueling is very, very important in type 1 diabetes. Our diet is medical nutrition therapy, targeted carbohydrate, therapeutic carbohydrate reduction. Our diet, therefore, scientifically, from what I've said, and logically, our diet should follow a low carbohydrate pattern, bearing in mind we do not need to eat carbohydrates to live, and carbohydrates will not make us deficient in nutrients. So one part of you says, what's the science say? Well, I think the science says, get your insulin volumes down, the glucose will follow. And your heart says, well, that's obvious, isn't it? You only need the one sentence, carbs raise insulin, and
Yeah,
that's it.
I think the other GPs out there in the world and the other doctors, one of the things that I believe have prevented a wider adoption of low carb, at least in type 2, we now have interventional trials making it very clear. In fact, in type 2 diabetes, it is widely recognized that reducing carbohydrates is the most effective way to improve blood sugar, or at least more widely recognized than previously. There's no, the days of dietitians demonizing low carb are over for type 2. But for type 1, I think it still remains a big challenge, particularly because, the highest body, I guess the ADA, certainly is not giving clear guidance on it. And one of the things that was interesting when we looked together at the data for our position statement from the SMHP, we looked back at all the data and we said, okay, Dr. Belinda Linares did a fantastic job maybe 3 years ago summarizing all the evidence. And a lot of it was observational, but some of it was very compelling. In fact, the 2018 report from pediatrics, presented a case series of hundreds of patients who had displayed phenomenal A1Cs, without any evidence of harm from hypoglycemia or DKA, using Dr. Bernstein's approach. So that was very interesting. But since then, when we reviewed the data, there's now more and more studies in type 1 diabetes comparing sort of higher carbohydrates to even modest carbohydrate reduction, and modest carbohydrate reduction had improvements. And then more recently, and this was about 2 years ago, that study was published, and more recently, there was a more aggressive reduction in carbohydrates. These are interventional, randomized, controlled trials now showing even more aggressive type 1, even more aggressive carbohydrate restriction, showing improved A1C with no evidence that there's higher incidence of DKA or hypoglycemia. So when you say that the science supports it, I agree with you fully. Do you think that our summary in this SMHP guidelines and our position that at the least that carbohydrate restriction or reduction, therapeutic carbohydrate reduction should not be withheld, and in fact should be recommended at the point of diagnosis. Do you think that there's enough evidence not to convince you and me, but to convince the Jane Doe and the Joe Smith doctor out there and endocrinologists that are seeing these patients day to day?
100%. I mean, if I had my time again and I knew this, I would be on to keto day one. It just makes so much sense. The other thing people don't mention very often, and which needs to be aired really, is this idea of soft side effects. So we're always talking about the hard endpoints of amputations, renal disease, heart disease, blindness, etc. But there are these day-to-day problems we get with blood glucose, and just a few examples. I put out a survey on my website, and we got 150 responses. Now, these were people that were keto advocates. They would sort of they would fly the flag for keto. So you have to understand that. But they were 50% of these people reported that they were brain fogged on a normal, well, I say normal, the wrong diet. They were brain fogged on the wrong diet, and when they went keto, of those that 50% that were brain fogged, 78% of those people their symptoms improved. Ditto vision. And things like postural hypotension, palpitations, joint pains. I had one guy attended my residential course on type 1. He was up for an operation for bursitis of the hip, sort of not arthritis, but inflammation of the hip. It's all gone within 4 months. His pain has gone. So it's reduction of inflammation of tissue as well. So the soft side effects improve enormously. So I can't see any reason not to adopt the most scientific principles from day one. What is the point of hanging around? The only point of hanging around is you'll destroy any remaining pancreas pretty quickly. And then obviously the insulin will have to be used straight away. But we have this amazing window called the honeymoon period, which makes no sense if you just look at autoantibodies, to me anyway. Most of the autoantibodies don't make absolute sense how they work. The anti-GAD antibodies, which are the most common, glutamic acid decarboxylase, is a neurotransmitter enzyme at the end of the day. And it probably has everything to do with insulin release, but nothing to do with destroying insulin. And zinc transporter antibodies, that's the zinc that holds the insulin in 6 molecules together in the beta cell, etc. And those antibodies appear, you develop acute, you probably end up in hospital. 20% of people still end up, unfortunately, with diabetic ketoacidosis in a coma. Their lives are saved. And then for a year or so after that, some people can go with almost no insulin for that. And people say,
we've seen honeymoons for years. We've seen a honeymoon for 7 years.
Exactly. You say, well, why is that? Why is that a honeymoon when in general belief, the antibodies have destroyed the pancreas, 95% of the pancreas is destroyed. So why does it suddenly improve? So if we've got any mechanism of holding it there, you know what I mean?
Yeah, it's actually do you mind if I come in with a little bit of with regards to autoimmunity, there's this it's an area I've been fascinated in because we don't know why the incidence of autoimmune disease goes up. Hashimoto's rates are going up. By the way, huge, as huge rate of Hashimoto's thyroiditis in the type 1 population and vice versa. And interestingly, there was a study from China just released maybe a year and a half ago, looking at hundreds of patients with Hashimoto's in 2 ways, looking at their antibodies, their TPO and antibodies and their antithyroglobulin antibodies, and then also examining them with an MRI through the thyroid gland, looking at the edema and associated inflammation. And the intervention was a randomized standard diet or low carb diet. And the low carb diet reduced antibodies and reduced edema on MRI in the thyroid. So meaning that there's some unique process to lowering carbohydrates, whether that's the anti-inflammatory effects of ketones or BDNF or if there is some link between carbohydrates and how they affect the gut, and how sort of gut permeability may be playing a factor in these autoimmune diseases. But we've seen also decades-long honeymoons with Hashimoto's thyroiditis. And if you stop and think about autoimmune disease as a several hit phenomenon, I think that's probably the best way to think about it, because it's not just the autoantibodies. It must be, first there's got to be a trigger, then there's multiple susceptibilities, and then you have disease after significant damage. So there's three key factors here playing in, and now, interestingly, in the type 1 space, to bring it back to type 1, which we didn't comment on in our position statement, but there are antibodies that seem to delay the progression of type 1, which I think is a fantastic advancement, I guess, in the field. So sorry to interrupt. I just had a little quick tidbit of info there.
No, that's very interesting with respect to autoimmunity in general, isn't it? Because people with celiac disease have there's people with type 1 have 6 times more incidence of celiac disease. That a gut derived autoantibody. It's fascinating that we may be able to understand in the longer term what actually causes type 1. There's several ideas at the moment, but there's no one unifying idea. There's lots of things that make it worse, but it's difficult to know exactly what causes it. But while we're waiting to find that out, I think we have to give the body the best shot. And from what I've said, I think reducing the insulin required is a good idea. But I think because carbohydrates put a load on the pancreas anyway, I think it just makes absolute sense from day one to get onto a keto diet. And
I wanted to come back to something you said, which I wanted to see if we could drill into it a little bit. You mentioned soft endpoints, and I was reading your most recent publication and the case report, and sort of reading through the patient's perspective, which I highly encourage. We'll put in the show notes. Everybody go read that paper, because one of those endpoints that I think are really discounted is the comorbidity with mental health, disease, anxiety, depression, mood disorders associated with type 1. Imagine, you are juggling, I heard somewhere, I'm not sure if this is completely accurate, but there are potentially, several hundred decisions a type 1 patient with type 1 diabetes makes in a day. And the mental burden is high, and the concurrent rates of depression and anxiety are through the roof. And your case report was so fascinating. Would you mind just, talking just a bit about that?
Yeah, it was a case of a person that had extreme anxiety about their diabetes, such that they found it very difficult to take insulin well. They found it very difficult to adhere to any particular diet. And the main author, Irene Weiner, from Norway, she took this person over. Irene's a clinically trained psychologist, and she also has type 1 herself. And she was able to manage this lady and persuade her to adopt a ketogenic lifestyle and manage her insulin much more effectively. They subsequently converted her to a pump, which made a modest difference. But the main thing was that this lady's anxiety symptoms plummeted. And there are lots of reasons for that. One of the big drivers for anxiety in type 1 diabetes is the feeling that you're not in control. And our clinicians, unfortunately, don't give us much hope, because we know what our end's going to be. And if we find we can't control our diabetes very well, you think, oh my goodness, I'm going to end up very early on with complications. But you have no way of controlling it. Every person with type 1, we all laugh about it, but we say you do exactly the same thing 2 days in a row and get completely different results. And that's because of other bodily processes going on which we don't fully understand. So to be out of
Inflammation, stress, sleep, I mean, just everyday living,
whatever, yeah. But you can do exactly the same thing twice, 2 days in a row and get different results. So being out of control, I think one of the most profound things for me when I found I could get control, it was a profound moment. It was such almost a relief to know that I could actually manage this condition. But before, you were chasing it, you were hoping for the best. You were taking your carbs, porridge every morning for breakfast, thinking, I'm going to do it properly today. I'm going to really count it. I'm going to inject my insulin properly. By lunchtime, it was all over. Monday morning you start again, and then next Monday you start again. And you think, I'm not doing this very well, and your HbA1c keeps going up, and then retinopathy screening is absolutely like any screening for health conditions, whatever, cervical screening, breast screening, it's quite an anxiety creating situation. Certainly in diabetes, because it's coming at some point. And once you get the control of your diabetes, it's the most releasing thing for your stress. And with this other poor lady that had in our case study, she was well beyond that stage. She had sort of severe mental health issues as a result of her feeling out of control. And it may be just the fact that she was in control, but what we talked about earlier, the effect on neurons of ketone bodies and how bipolar disease can be highly modified in a positive way by a ketogenic diet, suggests that it was not just the fact that this lady got into control, but the fact that this lady was on a ketogenic diet. And she's by no means better, but she feels that she can see there's actually a light at the end of this horrible tunnel that she'll be going down for a long, long time.
I mean, certainly I'd imagine, bolusing 3 or 5 times a day, versus bolusing none or maybe just once a day. Or even in the case that you had in this case report, it was a pump, I think it presents some interesting, just the mechanics of living with disease. Like, gosh, if you have to, I have patients who struggle to take a vitamin supplement, let's say once a day, but imagine, needing to do something 6 times a day and your life depends on it. I think the burden is so great. And I think the fear also is so great because, a hypo is truly, potentially lethal. So the stakes are very high. And anything we can do to stabilize that process, I believe will have forget about the unique effects of ketones and a stable sugar on the mind. I think just the fact that your disease is stable in type 1 and more manageable, gosh, what a liberation.
Absolutely. Just an example of that. When I cycled, as I said, to San Moritz to a conference. My talk was on sport and type 1 diabetes. So I thought, what better way to arrive than actually arrive in a sporty way? So, it was an old bike. I'm an old bloke, it was a normal, it wasn't one of these, mega sort of super athlete sort of things. It was just, I had 4 hours, 5 hours on my last day. I had a keto breakfast. And I went over a mountain pass in Switzerland, which wasn't one of the steepest and challenging, but it was still, 3 hours of continual climbing. It was tiring, put it that way. And then a lovely ride down the other side, thinking, well, if I did this on a motorbike, I wouldn't be wearing this sort of clothing at the same speed. I think this is nuts. When I got to the other end, my host welcomed me and said, "How's your blood glucose?" I said, "Do you know what? I haven't tested it all day." And that is the freedom you get from a keto diet. I set my alarms. Of course, I set my alarms. But the freedom to do that, concentrate on the beauty of the scenery, concentrate on, riding, thinking your own thoughts and not having to worry at all about type 1 diabetes. And it was literally that. I hadn't bothered to check it because I didn't think I needed to. I knew it would be okay. And how wonderful is that? Now, if I was doing that in a conventional way, carbing up, have loads of bananas and pasta for breakfast, and then injecting a reasonable amount of insulin, but reduced amount because it's very difficult to get it well controlled, and then eating 60 grams of carbs an hour, and if anybody eats while they're doing long distance activity, they know it makes you feel sick and you don't feel very well. doing all that and then having sugars that are going up and up and up all the time because you'd rather have a high blood glucose than a low blood glucose. And it's a nightmare, really. So to be able to do that without any worries at all, it just shows how freeing it really is. So I always say I'm someone cycling who has type 1 diabetes rather than someone who has type 1 diabetes who's cycling. And there's a big difference between the two because the preparation required is different.
Yeah. Yeah. I mean, I think that I think there's a lot of hope in the pipeline, as people like you and people like Dr. Bernstein who've been preaching this, and Andrew Kutnick and Belinda, Linares, and so many others in this space who keep pushing along, adding to the literature. I think it's going to bring a lot of hope to people with type 1. And I think, in a grassroots way, they're going to try exactly what you're saying here, lower their carbohydrates to 20 to 30 grams, potentially reduce the insulin with a good medical team in place in conjunction with their doctors using a CGM. And they're going to experience some liberation and some hope, and they're going to see better A1Cs. And I think as we get more studies, it's clear the way we're going. The frustration will be how quick it'll take to get there. And I'm hoping that the position statement we worked on will, be enough ammunition for our patients to take to their endocrinologist and say, you can't, you have to support me. And one of the things I'm excited about, at least, I've had some hesitations over adopting technology with the pumps, but the pumps are becoming more and more, aggressive and more, accommodating, and now some of the newer pumps here in the United States, the Medtronic pumps, you can target a blood sugar of 100,
Yeah.
which I think is an amazing leap, and if we can, so I think from all angles, the technology side, the CGM, the metabolic health push to really adopt low carb and not bias against it, all of these things, the antibodies that are now available, all of these things just bring hope, I think, to a group of people that really, really need it. So, give us some parting wisdom before we part ways. Give us some parting wisdom if you're type 1 is listening to this, or somebody with a family member with type 1 is listening to this.
Yeah, I would definitely take a look at ketogenic diets or therapeutic nutrition for type 1 diabetes. The reason is that it will improve your day-to-day life. Absolutely. It improves your mental clarity. It improves your ability to do physical activity. It reduces the number of hypos you're having. And for anybody who has hypos, you'll realize that even halving the number is fantastic. There's some evidence that it actually reduces it sixfold. The evidence from my study was that it reduces, nobody had increased hypos and everybody reduced about 30%, reduced 3 times or more. There's no other box to tick below that. The only caveat for pumps is that they're promoted as an artificial pancreas, and they're absolutely not. But the good side of a pump is it will help you to manage your blood glucose levels, and it's worth pursuing a pump. But I think a pump in isolation is not going to cut it, because you may get good glucose levels, but if your insulin volumes required to get those glucose levels are sky high, I think you will get good glucose control, but I don't think you'll get the multi-fuel potential of your body, which it requires. Our bodies require ketones, our bodies require to burn fats, and our bodies require to burn glucose. And we need to leave our bodies to choose what they burn, because they know best. Each tissue knows best what it needs at that particular moment in time. And I think that one of the dangers of pumps being promoted as, oh, eat what you like and the pump will sort it out. I think we've got to be very careful as clinicians to resist that temptation, because I'm sure there'll be a lot of pressure from our patients to say, why not, doc? And I think we have to be armed to say, this is why not. But it doesn't mean you can't enjoy your life, and it will mean you'll be able to control things much more effectively with the pump. Certainly those who find it hard to get around the idea of diet and and change their lifestyle, haven't got the capacity at the moment to change their lifestyle, a pump will help them with their overall glucose control. But I think as clinicians, we should be onto diet. We need to become experts on nutrition. We tend as doctors to do what I call whack-a-mole medicine. Do you have whack-a-mole? You know what whack-a-mole is?
Yeah, you hit one, and
So
then the video game, right? That
yeah, the glucose goes up, we bring it down, and then because the glucose and the diet causes problems, the cholesterol goes up and the blood pressure goes up. So we have a drug for that, a drug for that. The weight goes up. Now we've got a new drug for that, and you get heart disease, and we can put a stent in. And every time we get a side effect, we do it. We treat it, but most of those side effects wouldn't happen if you looked after your nutrition. And the nutrition guidelines for type 1 diabetes are specialist therapeutic nutrition. And our guidelines, the new guidelines that are coming out, make it absolutely clear that is why we need specialist nutrition for people with type 1. We are not the same as people without type 1. We never will be. We have to get over it. But there is an exciting world out there on a diet with multiple interesting menus and recipes. It will enhance your life and not diminish it. So there you go.
Absolutely. Thank you so much. Just for the listener to know, one thing I just want to add, and I forgot to mention, and I want to thank you for this, because I know that you are an integral part of the ketogenic textbook, particularly in the chapter on type 1 diabetes. I want to thank you for everything that you do. Thank you for coming on. Thank you for being an advocate for patients with type 1 diabetes. Thanks for the self experiments with cycling for several days and proving to the world and us what can be done. You're an inspiration, and I am honored to call you a colleague.
And likewise, Dr. Tro, I mean, this is a massive team effort by everyone that's in this space, and we're notching it up slowly. But without the ability to talk about it on your podcast and you to learn with others, and for all of us to push, nothing's going to change. So thank you for the opportunity.
Thank you.
If you enjoy the show, please consider supporting us on Patreon by going to lowcarbmd.com.